Thank you. I am pleased to introduce Dr. Marianne McKennett. Dr. McKennett received her MD degree from the University of California, Irvine School of Medicine. She did her family practice internship and residency at the University of California, San Diego School of Medicine. Dr. McKennett is board certified in family practice and completed 2 fellowships at the National Institute of Program Director Development. Following the completion of her training, Dr. McKennett developed the UCSD-affiliated Scripps Family Medicine Residency Program. In collaboration with UCSD, San Ysidro Health Center, and the San Diego Border AHEC. Dr. McKennett became the program director and continues to serve in that capacity. Dr. McKennett served as faculty with the California Cancer Detection Program. She is also academic community director at the UCSD School of Medicine and is clinical professor in the Department of Family and Preventive Medicine. This presentation is not industry supported, and Dr. McKennett indicates she has no financial relationships to disclose regarding her presentation. Dr. McKennett has a passion for provider and residency education to improve care for diverse populations. Breast cancer screening for primary care is a critical community need. I would like to present Dr. McKennett. The title of her presentation is Breast Cancer Screening in Primary Care. Please welcome Dr. McKennett.
Thank you, Elsa, and welcome. I'm here today with Kendra Brandstein, the director of the San Diego Border AHEC, who's going to be helping with any questions that come up during the presentation. So welcome, and please feel free to indicate any questions as the presentation continues. So in this short hour, I hope that we can review some issues of breast cancer epidemiology and disparities, looking at risk assessment of our patients and evidence-based breast cancer screening modalities, including self-breast exam, clinical breast exam, and mammography. If we have time, we will also review the competencies involved in a clinical breast exam. So just to review again, thinking about evidence-based approach to screening, one of the things that I always like to emphasize is that screening pertains to asymptomatic women. So we're not talking about women that have come to you with complaints of pain or lumps in their breast or nipple discharge. Those either findings on an exam or concerns expressed by the patient need to be approached in a diagnostic manner. But we'll be talking about screening of asymptomatic women, again starting with a risk assessment and talking about the role of these different modalities, self-breast exam, clinical breast exam, mammography, and then just very briefly touch on ultrasound and MRI. So just to set the stage, we have a patient scenario that was used in the New England Journal 2011 case presentation to discuss breast cancer screening, and that's of a healthy 42-year-old Caucasian woman who wants to discuss breast cancer screening. She has no symptoms. She had menarche at age 14. She had her first child at age 26. She's moderately overweight, minimal alcohol intake, and no family history of breast or ovarian cancer. She's never had a mammography done, and she's very concerned because she has a friend who's extremely healthy who's now being treated for breast cancer, and she wants to avoid this for herself. So this is not an uncommon scenario, and we as primary care physicians want to know how best to advise these healthy women. So we'll start with some background about breast cancer epidemiology. It is still the most commonly diagnosed cancer in women and second to lung cancer as a cause of death in women. In 2008, there were approximately 180,000 diagnoses of invasive breast cancer in the U.S., 68,000 women with carcinoma in situ, and over 40,000 deaths related to breast cancer. The lifetime risk, if you think of women living to age 90, is 12%, and the average 10-year risk for women changes through the decades. So for a 40-year-old woman, there is a 1 in 69 10-year risk. For a 50-year-old woman, a 1 in 42 chance, and at age 60, 1 in 29. And that increased prevalence or incidence will actually become important in how we counsel our patients about screening modalities. Now, one bit of, I think, good information, good news about breast cancer over the last decade is that the mortality continues to decrease by over 2% annually. And that is, and interestingly, in 2003, there was a marked decrease in incidence, and some think that that is also related to decreased treatment with hormone replacement therapy in early postmenopausal women. And at this time, the decrease in mortality is thought to be half related to screening, and also, and the second half related to actually improved treatment of breast cancer, such as chemotherapy and the long-term use of tamoxifen and Femara modulators, hormone modulators. So both treatment and screening play an important role. I always like to include issues of disparity in presentations because it's important to look at who doesn't get screened. If you look at age-adjusted breast cancer incidence, the incidence is greater in white versus black women, but mortality rates are higher among black women and other women of color. In 2011, there was a study looking at the 25 largest U.S. cities and looking at breast cancer mortality, and non-Hispanic black women are more apt, have a higher mortality than non-Hispanic white women diagnosed with breast cancer. And you can also see that in general, women of color are diagnosed at a later stage of breast cancer. And why do these disparities exist? Factors that are linked to lower rates of screening and later stage of diagnosis. So there is a correlation with lower socioeconomic status and lower education level, which may lead to less access to screening and treatment. In general, Medicaid recipients and uninsured have later stages of diagnosis and a decreased survival time from their breast cancer diagnosis. And Hispanic women have lower rates of screening at all income levels. And some of these may be related to fear of diagnosis and other cultural views of gender issues. But it is important to think about how to reach women that are not traditionally screened and what can be done to improve their rates of screening. So actually, community screening was looked at by quite a few studies, and the Cochrane Review actually looked at 150 articles about community-based breast cancer screening, and they picked 59 articles that they felt were met criteria to be reviewed because of a well-designed study. And they looked at 5 active strategies that showed improved rates of screening. And that some of those are listed here, such as a letter of invitation, mailed educational materials, an invitation and a phone call, and training activities and direct reminders. And you might notice here that the types of strategies that really led to increased screening were very individually focused. So outreach, but on an individual level, such as a pro-mortem model. For example, here in San Diego, there's been a Por la Vida project going on for years, which brings women together in naturally occurring social groups with a curriculum and reminders around breast cancer screening, and it's been very successful. Another bit of good news on the next slide is that California, in particular, has really increased access to screening for low-income women. CBE program, Every Woman Counts, which is state directed is a community-based cancer screening program for low-income women, which includes clinical breast exam, mammogram referral, and tracking, and is really if you couple this sort of access with the kind of individualized outreach programs, we can really improve and increase screening rates. And this is not on the slide, but we just received very good news also in California about the Low Income Health Plan, or the LIP program. As of February 1st, began offering breast cancer screening services for low-income women that had previously not been able to access that service. Okay, so where to go from here? In 2011, the U.S. Preventive Services Task Force kind of put everybody on their heels when they started to put out screening guidelines regarding women at age 40, saying that traditional breast cancer screening services or routine breast cancer screening services such as mammography might not be indicated. And that really, I think, made everyone look at breast cancer screening again and try to make some logical decisions. So we'll try to go through starting with risk assessment and then work forward through the different modalities to the most recent recommendations. So risk assessment, just in general, should be applied to any woman. Age is actually your most important risk factor for developing breast cancer, as well as a variety of assessments of first-degree relatives with either breast or ovarian cancer. Previous breast biopsies are also a risk factor, not because of the biopsy itself, but it says something about the type of breast tissue, and particularly women that have findings of benign proliferative disease on their breast biopsy tend to have a higher risk of breast cancer. And then age at early menarche and late first delivery are probably markers for increased estrogen exposure. But you will see, in starting with risk assessment, the screening decisions are actually probably more complex than what we originally thought about breast cancer. Just a moment. So this is actually a table that's probably a little bit too small to see, but looking again at breast cancer risk factors, just to keep in mind that the gene abnormalities, the BRCA genes, are probably your highest risk factor, 10 to 32, a relative risk increase of 10 to 32 times. That is not the majority of women that we're talking about with breast cancer. Most women are of more average risk, so we're not going to really talk about the BRCA situation. So family history without the BRCA mutations are anywhere from a relative risk of 1 to 4, and that depends on how many relatives and how close they are. Again, breast density or atypical biopsy also are significant relative risk increases. And remember that ovarian cancer and breast cancer as family history need to be considered. If you are working with your patient and starting to talk about risk assessment, there are some National Cancer Institute online risk assessment tools that can be helpful. I think they're actually best done in collaboration with your patient rather than sending a woman off to do that on their own. But just to let you know that if we were to run the numbers for our original patient here at age 42, she has actually quite an average risk. Her 5-year risk is 0.7%, which is an average risk for a 40-year-old woman. And then her lifetime risk is 10%, which is actually a little bit lower than the lifetime average of 12%. So that's just another way that you can use these tools to talk with your patient. And this just, again, talks about age as the largest risk factor, and kind of the curve, as you see, bends right around age 80, and that will be important when we talk about how long do we pursue breast cancer. And again here, another chart to address age-associated risks, but also note that death from any cause increases dramatically, whereas the death from breast cancer actually does not increase that much after age 70. This is too small to read, but the message here is that all screening should start with a discussion of risk rather than a prescription to a woman of, okay, it's time for your mammogram, it's time for your breast exam. A discussion of risk should begin at age 40, if not sooner, and really should include the benefits and hazards of mammograms and screening, and what does it mean if there is a positive result, and which may or may not be a true positive. So this is really here just to emphasize the importance of having a dialogue with your patients and not just prescribing treatment. One thing that to mention, and we'll talk about later, is after age 70, that discussion also has to include what the individual's 10-year life expectancy is and what are their chances, as we noticed earlier, of dying of something else. Maybe this is a patient with heart failure where breast cancer screening may not be the most important health issue for them. So now we'll proceed to talk about the recommendations about each of the different modalities. So self-breast exam, which was a very empowering recommendation for women in the past, has probably come under some more scrutiny now. Many women do feel comfortable with a breast self-exam because they are more aware of what's normal in their body. But if you really put evidence-based approach to this, large trials don't show any reduction in breast cancer or all-cause mortality, and that was reviewed quite closely by the Cochrane review. And then in Russia and Shanghai, there were studies of almost 400,000 women looking at self-breast exam versus no intervention. And probably the most important outcome is that more biopsies, benign biopsies, are done when self-breast exams are done, but not more diagnoses of cancer. And so actually the recommendations regarding breast self-exam have really changed over time, and the Cochrane review actually felt that concluded that the increased number of biopsies was actually a harmful outcome, and the U.S. Preventive Services Task Force most recent recommendation is against teaching self-breast exam as an actual D recommendation, which to them says that it causes more harm than good. It's not an intermediate recommendation. Now, the American Cancer Society still gives self-breast exam as an option for women in order to know what is normal, and I think that's the way it should be presented to your patients if they do choose to continue. And also, women should be taught correctly if they do choose to do a self-breast. Now, clinical breast exams have also come under scrutiny, which is the exam done by the provider, whether it's a physician, nurse practitioner, or physician's assistant. And the studies do show that up to 5% of breast cancers are identified by clinical breast exam alone and might have been missed on mammogram. Particularly, that is particularly true in women with dense breasts where maybe the mammography techniques are not quite as conclusive. But again, in community-based studies, about 4% of women with abnormal, so two things, 5% of cancers are identified by clinical breast exam alone, but in a community-based study, only 4% of women with an abnormal clinical breast exam had ended up with a cancer diagnosis. And then there was a Canadian National Breast Cancer Study that used clinical breast exam with and without mammography and found a very similar mortality. So the U.S. Preventive Services Task Force most recent recommendations found it as an I recommendation, meaning insufficient evidence to recommend for or against a clinical breast exam. So where does clinical breast exam fit in? One of the issues related to clinical breast exam is that the technique of performing the exam is very variable. And that's, again, if we have time, we'll go over a very scripted method to perform a clinical breast exam. So the variable technique probably affects its accuracy. But it may, as I said, have a specific contribution in dense breasts where mammography is a little bit less accurate. And back to the technique, there has been a very small study on using silicone breast models, the high-quality silicone breast models, that show that teaching medical residents a standardized approach to clinical breast exam does increase their ability to detect lumps. So that's an indirect method saying that clinical breast exam is most valuable when it's performed consistently and accurately. Now, mammography. Obviously, this is the core screening tool, very, very important. 8 randomized trials have addressed both effectiveness of mammography. The Cochrane Breast Cancer Group has looked at 7 studies, and the relative risk of, when you combine those studies, is that you get a relative risk reduction of 0.81. Now, that does for mortality, for screening mammography, leading to decreased mortality in breast cancer, not just diagnosis. Now, the relative risk for mortality changes over years. So for age 40 to 49, that relative risk reduction is 0.85. For age 50 to 59, it's 0.86. But the big difference is over age 60, where you see a relative risk reduction of 0.68, and we'll talk about some of the reasons why that is. So definitely the other outcomes, besides some mortality decrease, is that lumpectomies, mastectomies, and radiation therapy and chemotherapy are all things that increase dramatically with more screening. Next slide, please. Yeah. So again, this is a little bit busy, but talks similarly about the differences in mammography effectiveness depending on the age of the woman, and it looks at relative risk reduction but also number needed to screen to prevent one breast cancer death, and looking at false positives and false negatives. So again, age 39 to 49, 1,900 women need to be screened. 50 to 59, 1,300 women, and age 60 to 69, only 377 women, and that's because of an increased sensitivity of the mammography in that age range, increased incidence of breast cancer, and a decrease in false positives. So Cochrane review concluded that screening is likely to reduce breast cancer mortality, because that's ultimately what we're looking for, not just diagnosis, but decreased mortality. And you do get with that, you do have to accept a certain amount of potential overdiagnosis or overintervention with diagnoses of things like ductal carcinoma in situ, which may or may not ever lead to cancer. But that's always the balance in screening. And so if you just look in general, over 2,000 women being screened for 10 years, 1 will have their life prolonged, 10 women will be treated, you may say unnecessarily, but will be treated or have more procedures done, and 200 will have some degree of stress related to their screening. Now let's look at women 50 to 69. I think this is the least controversial age range, and really all groups recommend universal screening during this age range. And it's very clear for women in their 60s that there is an advantage to breast cancer screening and a pretty clear reduction in mortality. The group in the 50s is a little bit less clear, but still shows a fairly significant reduction in breast cancer deaths, as you can see. Now, the other group that is starting to become a little bit clearer are the women over age 70. So over age 70 to 80 becomes a little less clear, but there likely is a decrease in breast cancer mortality, just remembering that as you start to go over age 70, you really need to think about other comorbidities and make sure that we're not screening for something that is very unlikely to be the cause of the woman's death, if that makes sense. So, and then most groups are not recommending routine breast cancer screening over age 80. So now let's talk for a moment about the most controversial group, which are women from age 40 to 49. This is what created all of the uproar when the U.S. Preventive Services Task Force suggested that screening in the 40s might not be necessary or recommended. So there is no single randomized trial that shows a clear benefit, but when you analyze a group of studies or pull out the women from this age range, they do show a 15 to 20% risk reduction of breast cancer mortality, and that leads to a relative risk reduction of 0.85. So normal being 1, so it's clearly less than 1, so that is helpful. However, there are some questions that come up that make this a little bit difficult to interpret sometimes, because women can start their screening in their 40s but have their diagnosis, let's say, at age 52. Well, that looks like screening in the 40s was helpful, but actually if they had been screened at age 50, they would have been diagnosed at the same time. So these are the sort of tricky questions that come up with screening. There wasn't the age trial, tried to pull out that confounder and looked at women only from age 39 to 48 to kind of close that question a bit. And that one showed some reduction in death at 10 years, but it wasn't statistically significant. Confidence interval, as you can see there, crosses 1. And it was this trial, I think, that led to some of the questions. And this is not, the false positive rate is certainly higher in this age range because of a couple of things. One, the risk of breast cancer itself is lower, so you have less prevalence, and the mammography may be a little bit less sensitive because women have denser breasts at that age in the premenopausal time. So the benefit-risk ratio is a little bit complicated there. But you are dealing with younger women and with an increased life expectancy, so preventing even one death in that age range is looked on, positively. So again, just a little bit more about the controversy among women in their 40s. As I mentioned, mammography may be a little bit less sensitive. There's also some question about breast cancer in younger women. The premenopausal women still with higher levels of estrogen, that the disease is a little bit different. There is often a faster spread of cancer. Is our traditional screening even the right approach for younger women? Again, as I mentioned, there's some question about screening in the 40s and age 40s and diagnosing in 50s. Where's the value of the screening? Probably didn't start till age 50. If you look at all of these studies and look at screening effectiveness, the most effective screening is actually after age 55. Now, some people have also looked at mammography technique. Pretty much most centers are really looking at digital mammography now, which is very important, particularly for younger women with denser or premenopausal breasts. And definitely the DMIST study, although in a sense there was equal sensitivity and specificity looking at film versus digital, digital is much more sensitive for younger women, the premenopausal women, and pretty much those changes have been made at large centers. The technique of the centers is very important. So now the recommendations, current, American Cancer Society recommending that women age 40 and older should have a mammogram yearly while they are still in good health. Again, looking at comorbidities. The U.S. Preventive Services Task Force, which does tend to be a little bit more looking at the population as a whole, where American Cancer Society tends to be a little bit more individual focused. So it's good to look at both recommendations and then discuss with your patients and come to the conclusion that's best for them. And the U.S. Preventive Services Task Force recommends biannual or every 2-year screening for women ages 50 to 74, and they felt that screening before age 50 is an individual decision and should be made in collaboration with education and discussion with their providers and looking at their own individual risks. So the next slide compares the guidelines of the different groups, which is U.S. Preventive Services Task Force and the American Cancer Society are generally looked on nationally, but you can see that there are recommendations from National Cancer Institute that look at mammography, clinical breast exam, and self-breast exam. The things that are true are self-breast exam tend to be dropping out now. Clinical breast exam is in that intermediate stage, and then mammography, there is some discrepancy between whether to start always at age 40 or to wait until age 50 with individual discussion for the women from 40 to 50. Just a few things that, again, need to come into the conversation about risk and screening are these concepts of lead time or length bias, which means that, similar to what we were talking about, women being screened in their 40s and diagnosed at age 52, that survival time includes the time between the detection and when they would have been found clinically, which means that an early detection, let's say even at age 45, and treatment, let's say that woman actually dies at age 60, and so it looks like they live for 15 years, but it's very possible that if they had been diagnosed at age 51, they would have also died at 60, and they would have only lived 9 years. And it looks like screening helped, but maybe not if the time of death is the same. It's a little bit complicated and maybe something we don't like to think about a lot, but it is something to consider. And then overdiagnosis bias is something that's coming up now, which is there are some early studies that are showing that some breast cancers might never progress even if they aren't detected early. And we don't know at this point which ones those are, and certainly don't want to underscreen. And then ductal carcinoma in situ, there's a question of how aggressive to be about that diagnosis. And in the U.S., we tend to treat that very thoroughly and aggressively. In some other developed countries, that's not treated in quite as aggressive a manner. Then there's another question about healthy volunteer bias. In general, the healthiest of the population tends to be screened the most, and so that's just another thing to consider. And just not to forget that there are some risks to mammography, very similar to what we were talking about earlier, that there are false positive results, which then lead to increased anxiety, fear, further healthcare visits, and invasive procedures. We mentioned the ductal carcinoma in situ, pain and radiation, although radiation these days I think is not considered such a high risk, and then false negative results, in particular in younger women. This is actually also another slide that's a little bit too busy, but the 4 areas that they group the mammography risks include false positive rates that lead to biopsies and extra healthcare visits, false negative rates, which can give you a false sense of reassurance, overdiagnosis, and then radiation exposure. That's it. And then just looking at women, sometimes it's hard. Sometimes it's hard to know when we talk about 15% and 20% reduction. Sometimes it's good to actually look at real numbers and see what happens. These are just a couple of 2 charts here. One that looks at 1,000 women if they were to get annual mammography for 10 years. What would happen to them? depending on your age when you start. So if you're 40, you can see that depending on when you start, you have greater chances of certain outcomes, and false positive rates are higher in younger women, as you can see. And then actually the chance of having a biopsy is pretty consistent. About 200 women will have a biopsy if they are screened for 10 years, and then out of 1,000. And then developing breast cancer, as you can see, 40-year-olds, 15 would be cancer would be detected sometime in those 10 years, 28 in age 50 and 37 in age 60. And this is just a little bit another step on the specifics of the developing breast cancer, as we mentioned, 15, 28, and 37. And then so of those women having breast cancer cured by treatment, no matter whether they had been detected by screening or not, you'll see there. And then ductal carcinoma in situ, diagnosed because of mammography, anywhere between 3 and 7. So it's a small number. And your life saved by screening mammography, 2, 4, and 6 out of 1,000. So it's sometimes good to know what the actual absolute numbers are. I'm just going to barely touch on the question of ultrasound. Ultrasound is considered a screening and diagnostic tool for younger women, particularly even under age 40, because there you're often dealing with cystic structures or fibroadenomas, things that are more easily evaluated by ultrasound. And so it has its role mostly in diagnosis rather than truly in screening. And that was looked at by the European group too, trying to see does ultrasound have a role in just basic breast cancer screening? Not really. Right now it's primarily used for workup of abnormal findings. And then the second modality that you sometimes see advertised is MRI. Really the role of MRI is in the hands of the specialists and in special situations. Women with BRCA mutations, strong family history that include the BRCA mutations, those with high lifetime risks for breast cancer, women that have had direct chest radiation at a young age, which are at very high risk for breast cancer development, and then often post-diagnosis in complicated situations where there's more need for specialized imaging. But this is not something that in primary care that we would be doing an initial referral to MRI for screening. And I think that's important to know because, we just even in our office this week received advertisement from a local MRI group for breast cancer screening, and so it's just not a standard recommendation at this time and very costly. So what do we recommend? I think like any step in medical treatment, this really needs to be a process of shared decision-making with your patient, having an individual look at their risks of breast cancer, both lifetime and 10-year risks, beginning those discussions certainly by age 40, if not a little bit sooner, to set the stage, and have a collaborative decision-making process for women between ages 40 and 49. And then working together through any of the consequences of having screening done, and that might lead to increased biopsies, and supporting your patients through the whole process, no matter whether they end up with a benign diagnosis at the end or a diagnosis of cancer. And so, I think each of us would have a different, maybe a different advice for the woman that in the initial scenario. There's no doubt that even though her breast calculator put her at slightly less than average risk, there's no doubt that having had a close friend with a significant diagnosis is probably going to affect her wishes regarding screening, and I think that's absolutely something that we need to respect and work with our patients. So it's never one easy answer. So if we have a few more minutes and there aren't questions, I could go through the clinical breast exam proficiencies that are recommended by the cancer detection program in the state. So why don't we do that? So we can move to the next slide for that. That, again, as remembering that clinical breast exams are most accurate if they're done consistently and by trained providers. And so they are helpful in finding masses missed by mammography, masses detected by women, correlating with mammogram findings, and then abnormalities in women who might not want to have a mammogram done. We want to make sure we do a good exam. So commonly what happens is the breast does not get adequately, in short, the breast does not get adequately examined. Either the pattern is irregular, so you miss areas, the axillary tail is not examined, the nipple or areola complex is not well examined, and the pressure of the palpation is inconsistent and may miss lesions that way. So again, skill and experience of the examiner, the time of the exam, and then the characteristics of the breast being examined, whether dense or nodular, all affect the sensitivity or specificity of the clinical breast exam. And sometimes because this exam does take longer, I will actually say to my patients, you know, this exam might be longer than what you're used to for a clinical breast exam, but this is the reason, so they don't think there's something odd about that expanded exam time. Okay. And this is a little bit of an older slide, but the general, not so much the numbers, but the general idea is that, you know, the more experienced and the better exam that's done, the lumps could be detected at an earlier stage. Now, this this cartoon I have to give complete credit to the cancer detection program, but I love this because it's just when you don't consistently examine the whole breast, just as this lawn is not mowed in a consistent manner, you can say, oh, great, your breast exam is normal, but you're giving a woman a false sense of security because it wasn't actually done correctly. So why don't we go over the quick steps, and they're all P's, so this is the first P is perimeter. So I think it's good to think about the breast as more of a almost rectangular organ rather than a round organ. And that way you don't miss the chest wall areas. And so those lines are drawn by the mid-axillary line, the inframammary ridge, the sternum, the clavicle, and then just kind of a connecting line there in the from the clavicle to the mid-axillary line. And then the pattern, although circular pattern can be very accurate if it is done consistently, it's probably best and most recommended now to use what's called the vertical strip method. And you can see the correlation to the lawn in the cartoon there. But the idea is that you start in the mid-axillary line and never lift your fingers, and you actually are going as a vertical strip back and forth, covering the entire area of the breast. Now, what about the next P, palpation? Just in general, it's very best if you can examine each breast from the same side as the breast. Sometimes rooms are set up where that's impossible, but that is considered ideal. Use one hand for the exam. The reason is that just your sensitivity, if you have input, nerve input only into one hand, is actually better than if you're trying to use both of your hands. The bimanual palpation for the breast is not as accurate. Now, if you find an abnormality and you want to use the other hand to help you characterize it, that's one thing. But for initial exam, one hand is recommended. And then body mechanics, because it does take a little bit longer, you should make sure that you're standing in a comfortable manner and position. Now, palpation continued, you want to use the pads of your 3 middle fingers. That's the most sensitive area rather than fingertips. And at each of those, so it's not just dragging your fingers across in that vertical strip method, but at each point you want to circle and then slide your fingers without lifting. And so it's circle, slide, circle, slide. You can get a little mantra. And then you add the next P, which is pressure. And as I mentioned, there are superficial lesions, medium, and deep along the chest wall. And so at each of those locations, you want to circle light, medium, and deep, and then slide, light, medium, and deep, and then slide. And it sounds like, oh my goodness, this is going to take forever. But over the years, as I've developed this rhythm, it actually just comes quite naturally, just like anything with the practice. And those are references. Of course, there is more to the clinical breast exam, which includes examination of the lymph nodes, both the supra- and infraclavicular nodes, as well as the axillary lymph nodes. But that's another piece of the clinical breast exam. But as far as the actual palpation of the exam, the more consistent you can make it, the better and more accurate. And here's just a list of references that you could also refer to that look at the newer guidelines for breast cancer screening. So I hope you find this helpful in your clinical practice and in your opportunity to make these screening decisions with your own patients. Thank you.
Thank you.
Any questions or comments or concerns?
I did have a question.
Oh, hello?
Hi, this is Joanne Bedoin.
Hello?
Hi. So I'm the care line director for oncology for Scripps Health, and we were at a breast cancer task force meeting last week and discussed the Senate Bill 1538 and how we need to put the wording on our letters now if a woman has dense breasts that it increased their risk. And I didn't see that listed when you were talking about risk factors. And at the meeting, I was surprised one of the physicians said that having dense breasts puts you at the same risk as having a relative get breast cancer at a premenopausal rate or age. So, I mean, is the risk that high, and how should we be?
Oh, yeah, I think, I did have that, yes, breast density, and I think I referred to it from one of the charts, and that does increase, it gives you, that is actually correct, that your relative risk is 5 with breast density, which is similar to one of the higher family history risk is 4.
Oh, I see it there. Okay.
Yes, your more first-degree relatives give you a relative risk of 4, and significant breast density gives you 5. Now, of course, you know, how exactly to define breast density, like they say here, the very dense versus mainly fatty replaced. So it's the dense premenopausal breast compared to the fatty replaced postmenopausal breast. So I do think that that is accurate, yes.
Okay, so
it's here.
Now when the woman calls and says that she got this letter, and so she just had a mammogram that was negative, but do we trust the mammogram?
Mm-hmm.
How do we go through all of these risk factors?
Yes, I think looking at the other, really working with her to look at what other risk factors she may have. So are they additive? Is this someone with dense breasts plus other risk factors that would put them in a higher category? And that is exactly the patient where you want to have some confidence in the clinical breast exam as an adjunct, you know.
Okay.
That's my understanding. And so, for instance, you know, let's say with a woman with particularly dense breasts, and that there was even maybe a question on the clinical breast exam of an area that was denser and wanted to be focused on, and the mammogram was negative. Sometimes those are the patients that I will, as a primary care physician, that I will ask one of our breast cancer surgery colleagues or oncologists to actually re-examine that patient, so that I do take that seriously.
Okay.
Mm-hmm. That's helpful. It would be nice to meet you at some point.
Absolutely. Yes.
Yeah. Thank you.
Are you going to have these slides available to us at all? Or where? I mean, I'm just.
I think so. I can actually. I can send them to you. I can send them to you, and and would be happy to send them to you with the references and.
Yes, because we have to look at the risk factors. I mean, we have a work group that we have formed to decide how we will educate physicians, so that when their patients call, you know, how do they answer these questions, and really need people. This is an excellent slide that takes into account the other risk factors.
I think so. This actually, that one in particular, comes from the clinical practice review from the New England Journal, and it's quite recent. This is from 2011, so it's a nice updated review. Mm-hmm.
Thank you.
Sure. Okay.
Any other questions?
No, very helpful. Thank you very much.
My pleasure. Thank you.